Good morning, everyone, and welcome back. We're glad to have you all with us today. I'm Catherine Peers, Chief Operations Officer for the NTG, and joined today by our hub team, Kathy Bishop, Dr. Lucille Ezralou, Bonnet Fay, and let me see here, do we have Dr. Keller is with us, Dr. Sadowski is with us. We've got a full house today. And we're going to have a great little educational presentation by the ever popular Dr. David Frey. And I'm going to have Cameron introduce him in just a minute because they're colleagues, along with June Sadowski. But just a couple of housekeeping points. Everyone is muted by default. We are recording today's session, and everyone who's registered, we have about 110 people as of today that are registered, but because of work schedules and work commitments, not everyone is able to attend live. So we do record this and send that link to the recording out after the fact. We will also send a PDF of Dr. Frey's PowerPoint along with that. If you have any questions at all, please, during Dr. Frey's presentation, please put them in the Q&A box, and we will be happy to take those questions after he is done. His presentation is going to run about 25 minutes. And then we will move from that to our case presentation. We have a great case presentation this morning. But we're going to start off with Dr. Frey. I don't think of any other housekeeping things. Our next session is November 19th. And I think that's all I need to do. Most of you folks are pretty familiar with how this process runs. So with that, in the interest of time, I'm going to turn it right over to you, Cameron.
Thank you, Catherine. Good morning to everyone. I am Dr. Cameron Jeter, and it's my honor this morning to introduce my colleague and mentor, Dr. David Frey. I was faculty at UT Health Houston School of Dentistry for 10 years, and it was during that time that Dr. David Frey joined the dental school as well and came to me. I am an expert in neuroscience, the brain and spinal cord. He came to me and said, Cameron, I need you to join me as an advocate in Texas for those who have intellectual and developmental disabilities, particularly those who are adults, because it is difficult for them to receive adequate and proper oral health care. Dr. David Frey is an expert in health policy and as a dentist works to improve collaborative oral health care. And so I know his remarks today are going to be about that collaborative treatment team. Thank you, David, for being with us. I'll turn it over to you.
Thank you very much. Can you hear me fine?
We can.
Oh, super. So just so you know, I was a dentist for about 20 years, and then I was in public health for probably 20 years. And now I've been in education for the last 15 years. But I was the state director for developmental disabilities in Arkansas for 5 years, and then I was state chief for developmental disabilities for Hawaii for 14 years. So in that capacity, I was not functioning as a dentist. And what I've learned over many years is that we need to educate families and health providers and DD providers of services in the waiver programs and early intervention about oral health care, because collaborative care can reduce mortality. We don't think of that, but actually a lack of oral health can lead to brain infections. So the most famous case I can think of was an 8-year-old in Baltimore named Diamante Driver who died from an untreated dental abscess. So we, as a health profession, we need to be interconnected, and it really begins with prevention. So the main thing that I'm going to probably stress today is the information that you might need as a provider. So in the chat box, I'm just curious, is the people that are participating, if you could just put in what your role is. Are you a family member? Are you a provider? Are you a dental person or another health profession? So that, and I don't know, Cameron, if you can categorize that in chat and then interrupt me and let me know, then I can kind of tailor my presentation to meet the needs of the audience. So these are the objectives. I sent this actually a much longer version of this presentation. uh, on a PDF form, and it's available to you. But basically, we want to talk about behavior. That's one of the biggest reasons that we have to overcome challenges sometimes as dentists in order to provide oral health. And then I do want us to understand that policy decisions make a difference. Most dentists do not participate in Medicaid. In fact, it's really low. And what we've learned is that when you become family focused, you can actually get better outcomes. This was in the New York Times about 3 years ago. They had opened a new dental center for people with disabilities. I think that every dentist should treat patients with intellectual disability, not just have specialized care, but it is true that some people benefit from specialized care. And this is what our school actually does as well. But what I thought was interesting about this New York Times article was the response of families. And if you read this, it really talks about a dentist that doesn't take Medicaid. It talks about they really had to work hard to find a dentist that would do everything. And this particular dentist did it under anesthesia. But then the next two responses from family members were much different. And this one said, I've got a 17-year-old daughter with autism. It used to be a problem, but now she loves to go into the dental office and jumps in the chair. So what does that represent? That represents a bond of trust. That is a different philosophy that dental practice has engaged in. And then you see whoever W. Phillips is from Philadelphia said, we found a pediatric dentist that says it makes trips to the dentist no big deal. Again, they pay out of pocket. So the Medicaid issue is a huge issue because most dentists don't take Medicaid. And I'll talk more about that a little bit later. But policy decisions drive the availability. And I just thought these were some really interesting comments from parents. This was a case that I was brought to my attention by a parent here in Houston. And they went in under anesthesia and actually came out with 4 root canals. And the patient's mother said, I had no idea this was going to happen. So when you look at the preoperative x-rays, it's pretty obvious that there was decay that went into the pulp chamber that required root canals. But sometimes if you're doing only anesthesia dentistry, you don't have the x-rays before the case. And so you really can't explain things. And so that created problems. The mom was really unhappy with the outcome of how things looked. If you look at the picture on the upper left, that was after the root canals. The picture on the lower right was before the root canals. So even though the problem was solved from the dentist's point of view, as far as I've gotten rid of the infection, it created other problems that were far worse so this was a failure of a dental team and a family to really communicate. This is a case that I had a few years ago, which just points out the challenges that dental teams face. And this person had seizure disorder and had dilatant hyperplasia. So a lot of these cases can be really hard. For dentists, a lot of dentists think that the best way to treat people is with anesthesia and restraint. The National Association of State Dental Developmental Disabilities Services organization says, look, we should be reducing restraint. We shouldn't be doing more of that. We should do less. So that could be chemical restraint, which is anesthesia, or it can be physical restraint, which is a papoose board. And so what I'm going to talk to you really quickly is that there are many different options that go all the way to general anesthesia. And almost all the time, restraint anesthesia can be eliminated or at least only done very, very occasionally. So what is the third rail? So, railroad track has 2 rails. Well, there's a different way to look at it, and it's incremental community oral care. And it's working with behavioral analysts, using applied behavioral analysis, working with providers, working with families to do a lot of this in the home. And so this incremental delivery of care is a collaborative thing. And so the first place you don't go is your dental office. That's not where we start. That's the last place we go. And it's a paradigm shift. We actually are saying, look, we're not fixing teeth. We're not trying to make you look really nice. What we're trying to do is to prevent the need for us to do things. And so caries can be very damaging. These are cavities. Nursing bottle syndrome or feeding babies a bottle at night to go to bed can cause this. But what we can do is we can understand cavities. So for non-dental people, I want to go into this. Cameron, do we have non-dental people here, or are these dental people?
Non-dental, the split
Oh,
between family members and providers of IDD services.
okay. So I'm going to go into cavities because dental people don't need to hear this, but the rest of you do. It's a bacterial disease. You get it. You actually get it from your mom most of the time. Uh, the bacteria gets in your mouth during breastfeeding. Well, what are we looking at on the slide on the right? This is a disclosing liquid that shows where the grooves collect plaque, and that is, on the left shows a cavity. So what's going on? Well, the bacteria are able to penetrate the enamel, and the enamel is really hard. We have something called minimally invasive dentistry where we don't drill everything out anymore. And we have new technology. We use lasers. A lot of times with silver diamine fluoride and lasers, we don't need to use local anesthetic. So we don't need to use shots. So understanding minimally invasive dentistry is real important. This is an example I did years ago, and I actually used a laser and no anesthetic, and we restored the tooth to look like that. That's the filling right there. So what do you see? Well, when we look at a tooth, uh, this is a cross section. And this actually shows what decay, how it starts, how it tunnels, and it can go all the way down to the pulp chamber. If that bacteria gets to the pulp chamber, you see in this particular cross section of the tooth, there's a pulp stone in that hollow space where the blood vessels and nerve tissue are. That's what causes people to need a root canal. And a lot of times non-dental people are not aware. This was a study we did of extracted teeth, and we cut them in half. And you can look on the left, you can see where the decay is, where it's starting. And on the right, you can see it did not make it through the enamel. Another tooth, the decay on the left looked very much similar, but on the right, it was much, much deeper. So this tells you why you have to have an x-ray. So there are lots of different ways to treat this, but understand one basic thing. The toothbrush bristle is wider than the groove. That's why bacteria packs down in that groove. That's why when you eat those hard candies that you get when you go to the movie, that's the worst because it packs all that sugar down in that groove and that causes decay. So getting people to understand what is going on and understanding the frequency of exposure is important. So you ask people, how often do you brush? And people usually say twice a day, morning and night. And then you say, well, how often do you eat? Well, I eat lots of times. A lot of times people with intellectual disability, folks use their favorite candy to get them to do something. And so they may have 3 or 4 times between meals during a day where they actually eat something that has sugar or carbohydrate that can then convert to carbonic acid and make decay. So what do we have to do? We have to start thinking differently about how to do it. So I'm going to get into it. I do want to say a little bit, a note. I showed you the earlier picture of the overgrowth of tissue. A lot of times when we're giving dilantin, we can have that gingival hyperplasia, that overgrowth of tissue. And if you can work with a physician as a dentist, a lot of times you can maybe use Tegretol and reduce that. But the physician says, look, I'm treating seizure disorder. And if the physician tells the dentist, they've got to have 3 or 4 medications to control this, then as a dentist, I need to be able to work with the family to try to reduce that gingival overgrowth and keep the mouth really clean. The biggest tip that I give to dentists is it takes a lot of time. And the time it takes is actually before the appointment, during the appointment, after the appointment. And so I have to stress the before the appointment. So what we want to do is we want to educate families. And our desire is to share information, and so we give a kit called a brush and bite kit, a desensitization kit, where you take these things home and you practice at home the things you're going to experience in a dental environment. And I'll give you a little bit more later. These are some of the things that we can give to patients. On the right, these are, for people that use nitrous, these are flavored nitrous nose cones that people can take. You can give them to the patient. They can practice getting used to this sitting on their nose. There's a lot of different ways to brush teeth at home. The surround sound toothbrush on the right, I've got a close-up of that. The open wide foam mouth prop is really good, and I've got two different things I use for that. Getting people to brush their own teeth is really important. I want family members to. If you have somebody that has the inability to grasp a toothbrush, there's a lot of things we can adapt. The bicycle handle is probably the easier one. The tennis ball tends to be too big. But what I wanted you to see, the surround sound brush actually brushes 3 sides of the tooth at one time. So if you're brushing somebody else's teeth, you want to be efficient and fast. If they're brushing their own, you want to be able to do that. The bite block, we have this triple bristle bite block, and you can actually tell families, hey, practice with this at home. Make it a toy, make it fun, so that when they do come to the dental office, they put this in their mouth and they'll keep their mouth open so that I can take an x-ray. So these are helpful tips that you can do before the appointment. After the appointment, we really do, or during the appointment, we need to train the dental team to understand that the parent needs to be in the room and the parent needs to understand that they probably need to stand behind the patient. So in other words, they're not in the line of sight of their adult child. I'm not a pediatric dentist, so that's why I refer to adult child with disability. Uh, what I don't want is what's called triangulation. I don't want the individual to be looking at me, then looking at the parent. I want them to focus on what I need them to do, but I want the parent in the room because I need them to make sure that I understand their child and their child's needs and that they understand I'm interruptible. After the appointment, we want to educate people who like doing day programs, the importance of oral hygiene during the day at lunch. And if we're going to give people a bunch of candy, then we need to actually figure out a way to keep their mouth clean and help them with toothbrushing. So these are things that we do after the appointment. And I think the most important thing is to celebrate small victories. And I'm going to get into great detail about that. This was Dr. Jacob Dent in Sugar Land. He was a dentist with adult child with autism, and he developed a sensory room on the right. And so the behavioral therapists, the OT, PT speech, they would come in and do their therapy in this room. And this was adjacent to his dental office. The entrance was from the parking lot. You didn't go through the dental office, but the back door would go to that operatory on the left. So this is a dental operatory or where a dentist does work. And what's so unique is there's no dental chair. He has a beanbag chair. He actually has two beanbag chairs. He will sit in a beanbag chair. He sits on the floor. He tries to keep his eye level below the patient. This helps build trust. Dr. Dent also came up with this brush and bite kit. It's available from a company called Triple Bristle. I don't know how much exactly is. I used to pay $20 for them. On the right, Advantage Arrest is not something that people can buy. Dentists can use this to stop decay. This is our directions on how to use the brush and bite kit in Spanish. And so we work with families. We try to help them understand. We can stop decay in its tracks. It stains decay black, and then we can treat the teeth. The other thing is this pre-appointment form, and I really like this. This is what we do to try to find out before we ever go see a patient what's going on and what's worked, what didn't work. Is there a BCBA? Has ABA therapy helped? Is a patient have receptive language, expressive language? What were those things that worked, like a social story in the past? Can we use physical cueing? I had a dentist one time who would tap the forehead of his son. His son had intellectual disability. He had trained his son that when he tapped the forehead, he would open his mouth and hold it wide for about 15 seconds. So that's an example of physical cueing. So these are things that we come up with before we ever even schedule and see a patient in the office. We want to know what the prevention plan at home is. We want to educate the family. A lot of this can be done through telehealth. It can be done over the internet. Then we get into the professional visit. I want to know what's happened in the past and I want to hear from the family. That's the pre-appointment form. This is a pre-treatment assessment form, and it's different than the pre-appointment form. The pre-appointment form is done by the dental team. This pre-treatment assessment form is done by a person that does applied behavioral analysis, like a board-certified behavioral analyst or a psychologist. We have trained OTs and PTs to do this, and they go into the home and they actually are looking at all the things that were required of behavior. So getting in the chair. This is what you take the brush and bite kit, the desensitization kit, and you come up, and if you can do over a 6-week period of time, every checkbox on the right, then we know we're ready to schedule a visit at the dental office. I ask the parents to tell me what's worked, where do I want to be. Every individual is different, and the family knows really what works best. For those individuals that live in group homes, it's the group home direct care person. And that individual knows what works with that particular person, and that's who I want in the operatory if the family member is not present. Trainings for you guys. The AADMD has the National Integrated or IDD Curriculum in Health Education. Uh, Anybody can sign up to get this as a learner access, and I think it's a tremendous thing. Maternal and Child Health Resource. I haven't checked to see if this is still online. It may be down due to the government shutdown, but there are a lot of resources available to providers and families. Access for All Smiles. Delta Dental Foundation does this. It's great. And then the niche that I told you about, please sign up for it. And we've got, I think, a lot more than 44 chapters now, but many people of all health professions have done this. This is very helpful if you are a community service provider and you want to educate caregivers or any of your staff about how to learn about oral health and how to incorporate oral health into overall health. And then this is kind of me teaching the niche project. And then the last thing is I have a disclosure, and that is I have a grant from the Texas Council for Developmental Disabilities, and they support me in promoting collaborative oral health. They also support this NTG effort. So I would thank you for participating and listening, and I'm open for questions. If you take your camera and you snap that QR code and you write in there UTSD lecture in the event, I'd be thrilled to get your responses and find out what's going on. So with that, I'm done, and I'll take questions.
Thank you, Dr. Frey. So we welcome any questions or comments. This could come from our hub team members who are experts in different areas of care for adults with intellectual and developmental disabilities, or those of you who are participants joining. We'd love to hear your comments or questions. You can either share them in the chat, raise your digital hand, or even the Q&A feature at the bottom of your Zoom window. Dr. Bishop, we'd love for you to join the conversation.
Yeah, every time I hear you, David, Dr. Sadowski, Cameron talk about oral health, I am just amazed. I've been in the special education, the IDD field all of my life and never once had a course, master's through PhD or undergrad about oral health and the importance of it and prevention and understanding some of the simple available tools and the understanding how we can prevent cavities. I guess I'd like your comments on that because this information is so needed across the lifetime and even more so in later life, which is what we focus on, because of the lack of usually, dental insurance, oral health insurance, as well as just available to people with the knowledge that you have.
Yeah, I appreciate the question. I think it gets to the point of health promotion versus health provision. So what we've done in our economy of health, we reward failure, if you think about it. So as a dentist, I make more money when you don't prevent things. So so we have to, it's a mind shift. But on the other hand, if you were going to get nutrition advice and health promotion, you wouldn't go to the hospital and say, take me into the operating room, the most expensive place in this hospital, and sit down and explain to me how to do nutrition. That would be an inappropriate. So that's what a dental office is. It is the cost of a dental operatory is almost $1 million. So it's $500 an hour to sit in that chair. That's not the place to do this. So the approach that I described is an incremental model where we flip upside down the delivery of care, and we don't try to do it first. Most dentists, when the families call, they say, yeah, come on in. And so they bring you into that chair, and then immediately they have the pressure of, I've got to do procedures today, and people aren't ready for them. And so then the families, everybody gets frustrated, and the dentist team is frustrated because they're not getting paid. So what we have to do is we have to really change the mindset about health promotion and prevention, make it a part of overall health promotion, get everybody in the health team to understand it. And then I think it can be very effective. And we've done research on this now for about 8 years with Baylor College of Medicine, and it's really been transformational. We've been able to see people who only went every 3, 4 years to the operating room and they had general anesthesia to get dentistry done, and we've had them actually to achieve oral health without having to rely on that. So that's a really good question, but it's a mindset shift for the dental team. It's a mindset shift for families. And I know for DD providers, we just need to share more information about what prevention really looks like and how we can do it everywhere. That silver diamine fluoride, it's my hope that someday a lot of people can give that and it not be restricted to people in a health setting.
Dr. Keller.
Yeah, thank you very much. David, hey guy, thank you so much. It's wonderful for you to help and support us. I've known David for, I'll say decades or so, but a very long time. And I'm actually thrilled to have you and work with you and be a friend. And and thank you very much for the presentation. And my comment is related to the importance of integrated care between the oral health provider and the medical provider. And I know I'm almost like I'm setting you off for this information. And the oral health niche that you had mentioned, I actually had written a chapter on neurologic complications in those with oral health needs. And so I certainly had a appreciation, understanding. So David, can you talk about the importance of integrating care between the oral health provider and the medical care? You kind of alluded to about,
Yeah, I touched on it a little bit.
drug
Actually, I touched
with
on
the
your
seizure
area in your
medication.
chapter a little bit when I talked about seizure disorder and medications and how
Right.
certain
Right.
medications can cause gingival overgrowth of tissue, and how it's important to communicate with the healthcare team so that, and you can comment as a neurologist, what could be done. But I know that another example is GERD. One of the most disturbing things is when we see mortality data on GERD for people with intellectual disability, many times it's not diagnosed until there's a stage 4 esophageal cancer. So what's been going on for years is an individual has had stomach acid coming through the esophagus up into the mouth, but they don't go to their physician and say, "Oh, doc, when I lay down at night, this happens." Because they're nonverbal, they're not able to, so it doesn't get diagnosed. And one of the things that we can do in collaborative care as dentists, we know that when a person has chronic GERD, that it changes the surface texture of the back molar teeth, and on the top anterior teeth on the tongue side, it turns the enamel thinner and makes the tooth look more yellow. So we can take a mouth mirror and look in a mouth and tell if a person has GERD without ever having them tell us anything. And that's something that we can share with physicians. The other thing that physicians can help us with is they can do swallow studies. They can do barium swallow studies, and we can learn, what's really going on with individuals. So we don't do that in the dental office. So I think the other thing, a lot of times dentists are uninformed about the best way to do a medical consult. Many times what we'll do is we just write down, this is the procedures I want to do, and I send it to the physician and say, I need a medical clearance because there's a heart condition or whatever. And the physician doesn't know how to answer the treatment, the dental treatment. What they need is more information about, okay, what's going on and what is that medical concern and complication that you have. So I don't think we communicate well. And I've seen medical clearance forms out of my dental school from students sometimes that say things like, we think you should change your medication because it's causing blah, blah, blah. That's not the best way to communicate to a physician because we're the dentist and we don't know all the reasons why behind the medication. What we can talk about is bisphosphonate, which is another example that if I've got to do an extraction and a patient's had bisphosphonate therapy for years, they can get osteonecrosis of the jaw after I do an extraction. So I need to be able to communicate. So I don't know if that answers it, Seth, but the collaborative treatments really it involves communication and understanding and cross training. We're trying to do cross education with nursing students, medical students, dental students. We actually bring them together and do activities together, and we're trying to promote that communication and understanding.
Well, I think the problem that I see a lot is we're siloed. I think and it's not just generally for IDD, it's for everybody. We're siloed, and it's not specifically only to oral health care and the medical care. It's within medical communities and what have you, that we really don't talk or communicate well. But definitely, I think from an oral health thing, I think in all the 30 years I've been practicing medicine, is that mostly what I see from a neurologic standpoint is facial pain. So I am often seeing patients that have already been through their oral health provider and had various procedures done for those individuals that are having facial pain, and then ultimately they'll see me and they might have some form of neuralgia or such like that. And I think the problem in the developmental population is poorly verbal or nonverbal people that are having pain in their mouth. And as you certainly know, how are they communicating to all of us? And it's often some kind of behavioral change. So I know that you appreciate that, David, in terms of behavioral manifestations that are actually reflective of an underlying discomfort or thing like that, and how we generally need to be very open-minded from the medical side, the oral health side, that behavior is a form of communication. We have to be really open-minded and really appreciative that that's what they're trying to communicate, and we have to really learn to figure out what that communication is, rather than thinking that the behavior is a manifestation of their underlying developmental disability. And instead of just giving them drugs to suppress or reduce behavior, you really need to understand, why is that behavior actually occurring?
Yeah, I think that's a really important point. We have a whole chapter in the niche thing about diagnostic overshadowing, which you just described, which is looking at the behavior and ascribing it to the developmental disability and not realizing the person's hitting their face because they've got a toothache. We all know cases where these kind of things happen. I know Dr. Sadowski could talk at length about how we do differential diagnosis for patients that have cognitive dementias. But I think there are many times that, as a dentist, we really have to think through the multiple things that could be going on. Sometimes the physician realizes it might be a dental thing, but even the dentist is challenged. Is this an abscess tooth? Is this a cracked tooth? Is this a sinus infection that's masking as tooth pain? There are many things that we can do as dentists to communicate better to the overall health team. But again, I would encourage people to take advantage of that niche curriculum. It says niche dental, but it's actually for all health education, all the chapters. And Seth, you were actually the author of one of the chapters. So I think what we would love to see happen is better training for families, providers, and health professionals in collaborative interprofessional care.
Thank you.
Thanks for this rich discussion, and thank you, Dr. Frey, for your presentation.
I'm going to leave now, but thank you guys for inviting me. Take care. Nice to see everyone.
As we do each month in Project Echo, we will now transition from our initial didactic presentation this month from Dr. Frey, now to our case presentation. This is an anonymized patient case from a fellow Texan, and I'm going to turn it over to Catherine Piers, who's going to help us walk through it and introduce family members that are here to help support and answer questions after the case is presented. So thank you, Catherine.
Thank you. And I have to say, I'm always really taken aback after I hear Dr. Frey talk and Dr. Sadowski about oral health issues. It has been, I'm with Kathy, I've been doing this work for 40 plus years now. I don't want to say how long I've been doing it. And until we met Dr. Sadowski and Dr. Frey and Cameron, really didn't have an appreciation for how, oral health impacts so many other systems. And I learned something new today, which was about the seizure disorder and the impacts that can have. That was new news to me. So, and we don't talk about this oral health issue anywhere near enough. So thanks to Dr. Frey, and thanks to Dr. Sadowski, who's one of our hub team members, for all the work you're doing, trying to raise awareness about this really important and largely overlooked issue. So with that, let me lead into our case today. I put the med list up on the screen so that, there we go. Can be looking at that while I give you some background on the case. We do have some folks here today who can respond to questions from the hub team when we get to that point. But we are here today to talk about a 52-year-old female with Down syndrome. Her baseline behavior was typically very happy and joyful. She's always lived at home and was previously independent with most of her self-care tasks, including dressing, bathing, and oral hygiene. Speaking of oral health issues. She attended high school, graduated from special ed at age 21 with the ability to read and write some words. She briefly worked at McDonald's, but left due to scheduling conflicts with her mom's work, and later assisted at her mom's office with tasks such as shredding papers and organizing supplies. She has some favorite activities, which include building Lego sets, coloring, playing skip bow. I must be old. I don't know what skip bow is. Maybe some of the hub team knows what it is. And going to the movies.
It's a card game.
It's a card game. Okay. She participated in Special Olympics softball and basketball from age 5 to 48 and has had a boyfriend for 8 years with whom she enjoys social outings. She's always lived with her parents, frequently stays with her sister to give her mom a break. Sister lives on the same street and is available to provide support as needed. Her mom is now retired, and this individual attends day hab Monday through Friday from 9 to 3. In 2022, saw the onset of some memory loss, and since then has experienced progressive functional decline. She's at the point now where she requires assistance with dressing, bathing, toileting, and cutting her food. Her ability to use utensils is becoming increasingly limited and may require finger foods. And at home, she engages minimally in those previously enjoyed hobbies, such as coloring, due to difficulty with fine motor control. In 2023, she started showing more confusion and forgetfulness, and in February of 2024, she had a foot fracture following a fall. She did have a brace after that, and once she was cleared to walk without that brace, she subsequently slipped in the shower and hit the back of her head, which required 3 staples. In June of 2024, that same year, she experienced her first seizure while at camp, and that resulted in some facial injuries and was started at that point on anti-seizure medication. Following these events, her functional status declined more rapidly, and in January of 2025, she had an MRI that revealed hydrocephalus, and a shunt was placed. In spite of the surgical intervention, she continues to this day to demonstrate progressive deterioration in her ability to perform activities of daily living. Her diagnoses are mild IDD, Down syndrome, hypothyroidism, hypercholesterolemia, asthma, anxiety, environmental allergies, seborrheic keratosis, seizures, and mild cognitive impairment documented in 2024, and the normal pressure hydrocephalus, and degenerative joint disease, cervical, which were documented in 2025. The medications are shown on the screen. She does have a vision impairment, which is corrected with glasses. We did have a number of recent labs provided to us, so because of privacy issues with the name on them, I did not put them up on the screen here, but our hub team has been able to see them. And if they have specific questions, we can certainly reference back to them, but there was lab work, an EEG, and an MRI. And the main concerns for the hub team's consideration today are any dementia-specific treatment options that might be helpful, any help with her issues of activities of daily living. How can they help her with bathing, eating, toileting, dressing, mobility, and continence? She is exhibiting some agitation and or aggression periodically. They'd like some insight into that. And possibly, in the nature of advanced care planning, the need for adaptive aid, maybe for mobility or safety in the future. And again, managing some of those difficult behaviors she shows. Her overall goals of care are maintain her safety, prevent injury, and support her happiness and overall well-being, while making adaptations to everyday activities to help make daily life easier and more manageable. So with that, Cameron, I'm going to turn it back over to you and the hub team.
Thank you. First, I want to thank the family of our patient today for submitting such robust material. That helps everyone on the call have a better understanding of her status and to discuss it more heartily with what we hope are some helpful outcomes. In this session, we'll have different hub team experts who themselves are anywhere from a neurologist to a geriatric dentist, neuropsychologist, weigh in with questions that they have. And we also invite our participants to once again type your questions into the chat or Q&A box that we will add to the list as well. Dory, thank you for joining. We'll have you answer some of these questions as well as they come in if we aren't able to find the answers in the submitted material.
Can I interject one thing?
Please.
I learned from my mom that the MRI that indicated the hydrocephalus, that MRI was conducted because they thought she had a stroke, because she had been walking sideways and having some stroke-like, I guess, activities. Or so the hydrocephalus was discovered. Then the MRI was the purpose of it was for the stroke, what they thought was a stroke, but it wasn't.
Thank you, because that may actually indicate hydrocephalus pre-existing longer ago. I'll let Dr. Ezralou, would you please begin our conversation?
Yeah, thank you so much. And thank you, Dory, for that clarification, because that was one of the things I was wondering about as well. Could we also make the screen, the information on the screen, a little bit larger? And it may just be my old eyes, but okay, thank you so much. So a couple of things that I was wondering about. One is she had a fall, and then subsequently, she had seizures. And I know that's probably something that Dr. Keller is going to want to follow up about a little bit more. But one of the things we wonder about is with the occurrence of seizures, is this indicative of the kind of seizures that individuals with Down syndrome may experience when they have dementia, as they're progressing in dementia? Or might they, or in addition, could it have been a follow-up to the fall? In other words, any kind of head injury that she sustained with a fall, might that have contributed to the seizure activity? So I am interested in knowing the current status of her seizures. So that's one thing. The other thing is I'm also interested in knowing the current status of the hydrocephalus. So I understand a shunt was placed, and it was questionable as to whether that had made any, had been successful. So that is something I am wondering about as well. I am wondering about her response to current memory meds that she's being placed on for memory issues. So there's hydrocephalus, and I know there was one other thing that it seemed to be that I was curious about. Oh, and then with that neuroimaging that did not find an acute infarct, so it didn't show the signs that she had recently had a stroke. However, there was neuroimaging that showed that she had what's called white matter changes, and that was diffuse, that it was kind of widespread throughout her brain. And I'm just wondering, what the doctors, if anything, made of that. So the hydrocephalus, the seizure, the response to meds, and the neuroimaging information about diffuse brain changes.
Yeah, so let me first address the head injury and the seizures. So to get more detailed, because I've learned some information since I submitted information. This is 2024. January, she fractured her foot. February, when she got out of the boot, she was a little unstable and slipped in the shower, hit her head, had the staples. Then in April, she had a seizure at church. So there were a lot of people around her to, help her as she was going through it. The seizure she had in June she had gone to the bathroom. She was in her camp cabin, had gone to the bathroom and started having the seizure in the bathroom stall. So it really wasn't discovered until she was, I guess, going through it, and that's where she got all the injuries. And I was with her, and she was very much, I've experienced people that have had seizures before, but hers seemed to be very intense, and she was out of it for a long time. And she did go to the hospital after that. And then your question about the hydrocephalus. So I asked my mom, and they really haven't checked it since the surgery to see how it's going, but it seems to be there hasn't been any issues, put it that way. And then you had asked about the white matter. And what was your question about that?
Well, it just that one of the findings was that no, she didn't have a recent stroke,
Yes, no,
but there had been white
she
matter.
absolutely didn't have a stroke.
So the findings were that she did not have a stroke.
But they couldn't explain, or they didn't have a kind of rationale for the because there were brain changes.
Lucy,
Yeah.
I can probably explain all that.
Okay, good. And then the last question, because I don't want to hog this, is about the response to the medications she's taking specifically for memory.
No, we do not see any indication that memory meds are working. Her memory continues to get worse.
Thank you.
All right, Dr. Keller, would you continue for us?
Sure. Yeah, thank you. And I'm very sorry to hear about your loved one. I mean, this is certainly a difficult situation, obviously, to say the least. I'm very sorry about what's going on. So I'm a neurologist. So I'm a neurologist, and I treat the seizures, I treat the dementia, I'm involved in the hydrocephalus. So I kind of, this is kind of what I do as a professional in all these kinds of things, to just give you a background of my comments that I'm about to give you. So, and these are my own comments on my own experience. So I would say, be careful what I say, but this is just give you some perspective. So I'll just start with the normal pressure hydrocephalus. How did they say for any certainty that there was normal pressure hydrocephalus? Because I can answer my own question, but I'm curious on how they came up with that. Because doing a shunt, which is basically, for those that may or may not know what a shunt is, it's basically when there's too much water in the middle of the brain, which is the area is called the ventricles. A shunt is almost like a straw. You use a straw, and it kind of goes from the top of the head through the bone into the brain and allows the too much water or spinal fluid to drain out. So how did they come up with the rationale that a shunt would be valuable to do it in the first place?
She had a spinal tap, and they analyzed the fluid.
Well, what it is actually is it's kind of like that, but it's not quite. What happens is, to get to know that removing the fluid by using a shunt, what they do is they remove the fluid. It's called a high lumbar puncture volume. So they take out a fair amount of water, and then they let the person walk, and it's basically related to their walking. So the shunt, even though you might think about it for dementia, to know if the shunt is going to be successful, it's to take fluid out by using a lumbar puncture or spinal tap, and then right away after the procedure is done, almost immediately, you get the person off the table and you say they walk better. If they walk better, then they do the procedure. They put the shunt in, and there's no immediate improvement. Often they don't do that. So that's I'm assuming that they had to do that. Does that recall? Do you remember that?
I don't recall. I know they analyzed it for infection and different things that would be causing this
Right.
accumulation of the liquid in the brain.
As I'm not surprised, but what it is that in many people with Down syndrome, they have what's called congenital increased ventricular size. So it's not related to something that was acquired through one's lifespan. It's something that related to their brain development that the relative enlargement of the ventricles could have been there almost throughout their entire lifespan. And I see this quite commonly in those with Down syndrome. And unless I really, 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 really believe they got what's called NPH. So I hate to say it, you did what you did, and God bless you for doing it. But in most cases, it's not normal pressure hydrocephalus. It's related to Down syndrome and atrophy from the brain. So that's that part. The other part about it is the seizure medication. And just to kind of clarify it is that, and this is kind of what Lucy Ezra was kind of alluding to, is that there are different seizure types that are specifically relevant to Alzheimer's disease and Down syndrome. It's called myoclonic seizures. So Dory, and I guess Dory, that's your mom, are you familiar with myoclonic seizures? Is that something you've heard of or aware?
No,
No.
no.
What they are is it's where the seizure is actually a quick jerk of an arm or a leg or their whole body, just like a shudder. And what happens with that, people fall down the ground and get injured. So sometimes with myoclonic seizures, they can injure themselves. So myoclonic seizures are very specific and related to the beginning and during the duration of Alzheimer's disease with Down syndrome. So have you ever noticed that there was that jerk or twitching or something like that? Have you ever seen that?
She still does that.
That's seizures. There are seizures. I'm not shocked you may not even make the correlation between what you're still seeing, and when you're describing seizures, then you're probably just describing other kinds of seizures, which are called generalized tonic-clonic seizures. So those jerks are seizures. They are seizures. And the goal of the seizure medication, and the one that is referenced here, is called levetiracetam or Keppra, 500 milligrams twice a day. Because the goal of it is to even stop the myoclonic jerk. So if the myoclonic jerks are still happening, that's not good. That's not good. So the neurologist, God bless the neurologist, also has to appreciate that the myoclonic jerks are seizures, and the goal of using the Keppra, the levetiracetam, is actually increase the dosage to try to also reduce the myoclonic jerks, which are seizures, if you can.
Okay.
And the other part about it, yeah, I'm sorry.
No, I was just going to say, in the middle of the night, I happened to get up and go in her room, and she was having what I call a seizure. The jerking, the after it was over, after she stopped
Right.
jerking, she couldn't breathe.
Right.
It was a constriction, I guess, in her chest. And
Right.
it took her a little while to breathe normally. Now I've seen one of those. The jerk, he did try to change her to Depakote one time, and it was like she was almost gone, catatonic. And
Right.
so
It's probably a side effect or sensitivity to the medication. And finally, I'll let Dr. Bishop talk a lot. But basically, the other comment, this is related to the medication that were mentioned already. The two medications that I'm looking here, one's called memantine and the other's called rivastigmine. Both of them specifically are different medications for Alzheimer's disease. And what I would definitely think about strongly, because of what you're not noticing of improvement, was your decision about just stopping those two medications?
okay.
Were that discussed? I mean, I would strongly consider them about stopping it. Or the other option is that the rivastigmine 1.5 milligrams, the other name for that is called Exelon. The brand name for that is called Exelon. And so 1.5 milligrams twice a day for that specific medication is the lowest dose possible. So if you're going to use any of these memory medications, then you should know if it's working or not. And if it's not really working, then either you stop it or then you go up to a dosage that you're trying to imagine and see if it works. And if it doesn't work, because the research on using these kinds of medication, those with Down syndrome, Alzheimer's, is not a lot of research that prove that they're valuable. So I think otherwise there's side effects. So I think you have to really look at those medications very seriously and say, is it really worth it or not?
Okay. Okay.
Thank you.
You're muted, Cameron.
Thank you. I was just saying, Dr. Bishop, please.
Thank you. I thought you were, but I thought you needed to know you were muted. Thank you. I'm a gerontologist um, with a specialty in aging with intellectual and developmental disabilities and dementia capable care is my other specialty. My fascination and my inclination is always to go to the practical, to go to the sensory issues, and to go to how we can make a quality of life and help support you as the caregivers and a better quality of life. My frustration today is I could give you probably 20 recommendations that you could do in the house that might help in terms of quality care and staying connected. I'm not going to be able to do that. So I'm going to ask a few questions, give a few suggestions of what I think additionally is going on. And Catherine, I would suggest I would like to, in one of our next sessions, do kind of a practical, here are things you can do in the home, the residence, practical, easy to do changes that can help support someone with dementia. So I think we should do that sooner than later if we have open sessions. And so I would really welcome and hope you would also come on for that as well. So I have a little time to go through and why. I'm going to ask a couple questions and I'm going to tell you the basis of what I'm thinking about for how you can help yourself in the physical and sensory environment. Unless I missed it, and maybe I did, has there been an actual diagnosis of the type of dementia?
No, just the
Alzheimer's. He
MPI.
called it Alzheimer's, and he's basing it on the statistics of Down syndrome.
Okay, that's what I was afraid of. Yeah. So I would advise you, you've got the diagnosis there. I try with your healthcare providers to look at today's symptoms and issues and focus on that rather than diagnosis of Alzheimer's disease, because I suspect there was not as complete differential diagnosis conducted as I would like to see, and probably others in the team, especially I know Catherine would be supporting that. So the visual impairments, she does wear glasses. I assume, I know you said the correction. How good is she about wearing them?
We got new glasses about 6 months ago, and she's great about wearing them.
Okay. These are probably more comfortable and better fitted to her than the ones before. How long do they take? And when, I don't know how often you go for a revisit, but is it quite a bit of time, and do they interact with you as they're deciding what correction they need to make in the lenses?
Yes, well, for the most part, I've had more success with an optometrist than an ophthalmologist. The ophthalmologist was a disaster. But anyway, yeah. So the optometrist was very, very helpful and worked with me.
Okay. You might want to request more frequent visits in updates and with the optometrist. Seth, I'm sorry, you can either cover your ears or I apologize ahead. I find nurse practitioners, PAs, often are the ones that will take more time and much better with families and caregivers in terms of really listening.
I totally agree.
We've seen that. We've seen that with her primary care physician.
There is one thing I don't think was mentioned, but she has, let me put it this way. She totally freaks out with busy carpet or lines in the road.
This is why I want sooner rather than later to do a session.
Yeah, it's really bad. Yeah.
Yeah. Let me give you a little background information why. And this is constantly growing, my understanding of it, and as there are more and more research. The only way we connect to the world is through the vestibular. Have you ever heard of the vestibular and the proprioceptor sensory systems? Okay, so we have the 5 primary. We're familiar with the hearing, hearing, vision, taste, touch. I'm missing one. Touch and smell.
Smell.
Yeah, smell. But the only way that the brain is able to receive the information, which is external receptors, is through the vestibular system, that has external receptors, joints and muscles, for example. I suspect with the falls and the seizures, your daughter is not moving and walking as much, and I assume she's probably hesitant and much more afraid. Your daughter and sister, I'm sorry. So her muscles, she's probably had reduction in muscles. Her joints, there's probably osteoporosis or arthritis in the joints, again, not because of lack of movement, likely to be a loss. And so they're not receiving the information in the environment to locate herself in space. Busy carpets are some of the worst. Busy environments. So those are things you can start with, to have simple carpets if you have to have carpets. If you have carpets that they're flat and they're not fall hazards, using contrasting colors and simplify the environment around her, because the vestibular is the only way the information comes into the brain. The brain, which is damaged, it's being damaged with seizures, possibility of strokes. There may be TIAs that they're not able to measure that have happened, causing brain damage. And there may be this continued plaquing, neurofibrillar entanglements causing further damages if the Alzheimer's disease diagnosis is to be believed. All of that means that your daughter, sister cannot take in the information in the environment, cannot work with the proprioceptor system to locate her in space. So the best advice I can give you in this short time is to simplify the environment, use color contrast, create pathways. Always understand that anxiety is very much related to being lost in space and time, not knowing who she is, where she is, or what can be done. You can imagine the anxiety and the confusion. The other thing I advise, routine, routine, routine. Most of our reaction and functioning with the sensory information is through habit and routine. About 80 to 85% of our behavior is from routine. If your brain had to pay attention to everything, which is what her brain is trying to do right now, because the damage and the difficulty of the sensory information coming in and being processed, her brain cannot do the processing. And so it's great anxiety. She feels lost. Habit, habit, habit. Routine, even more important in my work over 30 something years, a lot with people with Down syndrome, is that routine and habit is even more ingrained and needed in people with Down syndrome. So as much as you can go to the old routines to connect to, make an environment that she can move safely through as much as possible. Understand you will need to be more supports and simplify. And so I'm taking up far too much time, but would love to do that session and make sure that you're on, because there are a lot of simple things, not even necessarily a cost to them, that can help make all of your quality of life better.
Okay, thank you.
Yeah, thank you. She has comfort in being at home, at my house, and at Dayhab. Anything outside of that, not good. So I hear what you're saying. Yeah.
Lucy, please.
Yes, thank you. And thank you, Kathy, for sharing all those wonderful practical suggestions. I just want to build on a few things. One is that an additional source of agitation or confusion may be depth perception problems. It's not uncommon for individuals with Down syndrome to have depth perception problems in which they cannot accurately judge things at a distance downward. Not only does that increase kind of safety issues, but or decrease safety, but it can lead to sensory kind of confusion and misperception of patterns and various things. So I wanted to make just a few recommendations just to build on some of the things that Kathy had mentioned. One is I do believe some source of this like agitation or anxiety or even aggression might be because she's overwhelmed and can't make sense of her environment. So I just want to lift up this idea of routine is important. Build on known interests. So right now, the idea is to shift to quality of life. What are the best things to maintain her quality of life? Maintain social interactions. So I understand that she has a boyfriend. So I think that one of the tools that you might want to look at is Jenny's diary, if you haven't seen it before, because Jenny's diary talks about a woman with Down syndrome and Alzheimer's disease as she kind of goes through her daily routine. And it talks about how to explain this to this person, Jenny's boyfriend. How do you explain the changes to him and to other people who may be important to your sister, your daughter, and do not understand for themselves what might be going on with her? And it's a way to be supportive of them as well as to be supportive of her. I think you'd find it very informative.
Yeah,
And
can I just say real quick, she does not want to be around him.
okay.
And I have, because I attended a conference and there was a session about emotional relationships with people with IDD. It wasn't specific to Down syndrome. He has Down syndrome. And afterwards I spoke to the presenter and I kind of told her what was going on. She said, talk to him, tell him what's going on. He will probably understand more than you think. So I've told him that. I said, she doesn't mean to be mean to you, but she just is not well.
Gotcha.
Yeah, but he still loves her though.
Well, that, loyalty.
Yeah,
So,
her social connections are pretty narrowed down.
because she doesn't, no longer has the ability to kind of maintain them. However, to the extent that you can, the fact that she goes to Dayhab is really excellent. If
Yeah.
you can get somebody who can come in and do an environmental assessment and look to see what might trigger her, like what are things that can be difficult for her in the environment? Where are the stressors? And some of the stressors are internal, her own confusion, pain, inability to effectively communicate her
Yeah.
needs and get her needs met. But some of it might be environmental stresses. And I would recommend Jenny's diary anyway for you to
We will. Yeah.
Thank you.
Yeah.
Thank you.
Yeah.
Catherine, please join the conversation.
Yes, well, regarding Jenny's diary, I will send you a link to that. It's free and you can download it online, and I'll send you the link to that afterwards. Lucy touched on a couple of things about, behavior-wise, about feeling overwhelmed and the importance of routine, as did Kathy Bishop. But you had mentioned that she becomes very upset about the carpets and the lines on the street. Does she become agitated and aggressive in other realms, and can you give us a sense of some of the other scenarios in which she becomes upset?
Yeah, one of the big ones is she wants to drink Diet Coke 24/7. And she's limited to that. And if she asks for one and you tell her no, she gets very upset. If you try to give her a bottle of water to drink, she gets pretty upset about that. One thing I had noted in the paperwork is that she is constantly saying, eat, eat. And I think you guys can tell me, I think she forgets that she eats.
She gets up from the table and goes in her room for a little while and comes out and says, eat. And I'll say, not yet. And she
gets mad.
claps her hands.
And break up your meals, snacks into small. And when you want to maintain her capacity to be able to connect to food and request and eat, break them up into small. You don't have to argue. She just ate. It's not yet. Don't think of meal times. Think as 1.5, 2 hours You know,
Okay.
when she's requesting, if she really has still the sense of hunger, you want to help maintain and reward that.
Okay.
Yeah, I would say, you know, you don't want to take things away, you know, but modify how they're offered. Will she eat like healthy snacks? Like I'm thinking little cubes or sticks of watermelon or apple slices for snacks, some of those
Yeah.
healthy foods.
She
And
she will, but sometimes you'll give her something and she'll say, real food.
well, I have a sensitivity to how she probably feels.
Totally understand. I agree. Comfort food.
Yeah.
You know,
She
and
she
again, I
knows
think,
she knows the difference between a snack and a
yeah,
meal.
yeah. I get, you know, I get it. Um, and you know, I think at some point you also have to ask yourself, you know, at some point it becomes comfort and her contented involvement in
Yeah.
things. And so, you know, maybe loosening up a little bit, unless they're a health, like if she was diabetic or something like that, then there are issues there that you'd want to consider. But, you know, maybe her happiness at this point and her comfort and her, to me, take priority. My dad had Alzheimer's and was diagnosed when he was 56. That's how I got involved in this. And I know at some, you know, we finally got to the point where it was his contented involvement in his daily life that became important. And if that meant kind of stretching the parameters
Yeah.
around things, particularly around things he liked to eat that maybe he shouldn't necessarily, as long as there are no severe health, you know, issues around that, you know, I think that becomes important. Um, and again, I think, you know, Kathy touched on the sensory, and I think that that really is true. We have a saying in, you know, Kathy and I do workshops all over the country, and one of the things we always say is behavior is communication. All behavior has meaning. And so when you see a behavior, no matter what it is, thinking about, could it be something in the environment? Is it an interaction with someone that she's had? Telling someone, you know, telling most of us no for something, you know, like when she asked for that extra Pepsi, doesn't go over well with most of us. And so I'm not surprised she might have have a reaction to that. If, you know, you could think about, you know, diverting her to a different topic or something other than the Pepsi, or maybe giving her smaller, you know, drinks of Pepsi spaced out more in the course of the day. But how can we sort of adapt these things that obviously have meaning to her, so that we aren't in the position of having to tell her no, she can't have one, because we know then that's going to precipitate a, you know, some sort of a behavioral issue. And I think keeping the environment as quiet and calm, and as, you know, Lucy and Kathy mentioned, you know, routine, that is so important. And I think, you know, Lucy's suggestion was about the environmental assessment of the day hab, and I think that's a good point. Day habs can sometimes, and I'm not familiar with her day habit, sometimes they can be kind of very active, very stimulating, you know, lots going on and people moving and sounds, and that may not bother her now. But thinking towards the future, if you do see her starting to show some signs that could indicate stress in that environment, you may have to start thinking at some point, do we need to cut back those hours? You know, do we need to look at, you know, some modifications to that? Behavior is communication. So when I see a behavior from someone, the first thing I always think about is what are they trying to tell me through this behavior? Because they can't verbalize and say, oh, I'm feeling stressed, or I'm, you know, I'm mad because I was told no, or that pattern in the rug is upsetting, you know, to me. So I don't want to hog the conversation. But I think it is important to always, when you see that behavior, don't think of it as, you know, sort of a psychiatric kind of issue because of, you know, dementia or whatever. You know, think about, what could this be a symptom of? What's she trying to tell us through this behavior? What's she communicating?
Catherine, you suggesting to have small drinks of soda. It triggers this small story that my own mother would serve soda in fancy glasses to my siblings and me as a small reward. little did I know that that also meant that the volume of the soda was less. And so we would sip from our little champagne flutes, thinking we were fancy ladies. And really, we were getting a mere 4 or 5 ounces of soda. So I don't know
Yeah.
if your sister and daughter would consider that to be fancy, but have a
Yeah,
little tea
yeah.
party.
Yeah, yeah. That's
Dr. Keller, please.
Yeah, thank you. I certainly agree with everyone and my colleagues are saying. I just have a few more questions, and I know we're coming to the end. My question is related to the usage of the sertraline, which is Zoloft, 25 milligrams, started in June, it looks like, for anxiety. What's your appreciation of what that's actually doing for her?
I think it helps.
And why do you think that way? Why?
The reason she got that he put her on it was she was having a great deal of frustration. Well, she still has the frustration, but it was worse. Her anger issues were worse. I feel like it helped. Maybe I'm
And the
just
reason I'm
depressed
asking,
as
I'm not
well.
surprised by it, is actually related to the dosage of it. The 25 milligrams, I hate to say a pediatric dosage, but it's almost like the lowest possible dosage. So
Yeah.
so one, it's picking the behavior, targeting what you're looking at, which is your anxiety and frustration, whether or not in other the environmental is hugely important to appreciate that and maybe not rely on medication, but also to pick the right dosage. And 25 milligrams, like I said, is very small, and maybe they're just being very conservative, which makes sense. But to make sure if you're giving anything, this goes back to the memory medication. What does it do? Is it doing well enough or not? And if it's really not, and if it's not suiting or giving you what you're looking to get out of it, then it goes from 25 to 50, and the maximum dosage is 200 milligrams. It just says that, I mean, not that I'm saying they would ever need 200 milligrams, but it's the
Right.
smallest amount possible. So if you're going to use it, you should use it. So I'll just give that
Right.
sense. The other question I have is when, and you kind of ran on all her activity, what she used to do was really great, and all these things she used to do. From the beginning of how this began, several years ago, right? It's only been a few years, right?
Yeah, about
Right?
22 was when it started.
So let's say 3 years ago. So, and this is kind of what I use in my mind that really talk about the stage of the condition and the progression of the problem. So you get a sense of where this is all going to go from here. So when you look at 2022 to now, 2025, how different is she from 2022 when it all started to today? How different would you say she is?
75% different,
In not a good way, right?
and not a good way.
Correct,
Yes.
correct.
Right. Right. And so
Her
what I do,
ability.
because I prognosticate. I'm asked as a neurologist to prognosticate all the time about how far it is and the future and all these things. I know this does not come as a shock to you with what you're seeing in front of yourselves right now about where this is all going to go is appreciated. Was this discussed with a neurologist about like the stage of the dementia that she seems to have, the little severity or the stage of the dementia?
No, no.
Because it is unfortunately Alzheimer's disease, and this sounds exactly like Alzheimer's disease, especially with the myoclonic seizures, especially in myoclonic seizures, these are often more progressive dementias. These are often more progressive. They escalate quicker. The life expectancy, sadly and tragically, and it's a very hard conversation to talk about this, but there's a reality that has to set in your mind about where this leads. And so eventually what happens is people can't swallow, they can't walk as much anymore. And then it really talked about the decision making on palliative care and end of life care. Were those conversations had with you about any of this?
No, he did mention though that he believes the lifespan is tops off at 60.
Right. So these are hard conversations, but because it's all related to planning,
Yeah.
planning on and right, getting, because when people advance, they require more and more care and support as you're seeing yourselves of it's needed. And
Right.
that's kind of why it's important to really, as hard as it may be to really appreciate certain realities of planning and anticipating so you can see ahead rather than almost like deal with crisis intervention all the time.
Yeah.
Like what's going to happen next. And because there are some relative predictabilities of what may lie ahead. And as hard as they're not to hear or think about it, these are things that are truthfully realistic that have to at least at some point be thought about so you guys can get in your mind about planning and preparing, honestly.
Okay. And it's crossed my mind. I haven't openly discussed it, but it's there.
Right. And I apologize for bringing it up, but I
No,
can't help
That's
myself.
fine. That's fine.
Yeah.
I have no problem with it.
Dr. Keller, do
Right.
you think that she needs any other testing right now to project, or is it not necessary?
Well, in terms of my own personal feel, again, I haven't seen her myself, but just based on what you're saying, it sounds like it's, getting pretty advanced. It really does. And in terms of any testing, I mean, I know Dr. Bishop mentioned about the differential diagnosis and what it is, but I think it's very important. It is indeed important to appreciate all the other additional factors that can, in anyone who's in this situation, will make it worse. Their behavior, their sleep, their pain, the environment, all those factors will absolutely contribute to making it feel worse. So anything that can be done to kind of lessen the situation and improve her quality of life, that's rich. I mean, that is so vitally important to really, again, because I think a lot of physicians are only looking at it's a dementia, it's an Alzheimer's, and they don't think about all the other associated factors that really have to, whether it's vision, hearing, sleep, pain, happiness, environment. And I think that's kind of where the physician themselves are not educated or trained, don't see that, and they only focus on what they've seen from and give a drug and, very black and white about certain things. So it's important to have a holistic approach as you're getting.
Thank you.
I have a question. When you do step up the seizure medicine, do you do it a little bit at a time, or do you just jump right in with the larger dose?
Well, what it is, this medication, levetiracetam, is despite the size of the pill, is actually mild. And one thing I'll just mention since you ask about it is one of the side effects of levetiracetam is irritability. So as the medication is given, does that contribute to her behavior? Is that as a side effect, as a problem? So the neurologist, again, I'm a neurologist and I use these drugs every day. Do they appreciate it? They should know that as a side effect. So if you're going to increase it, and the increasing would often be from 500 twice a day up to 750 twice a day. That's typically would be the usual, and they're, as you know, they're splittable pills.
Yes.
So sometimes what you do is you take 1.5 pills twice a day, and that's usually the next step as compared to doubling the dosage. So typically it goes from 500 twice a day up to 750 twice a day, especially if she's still having what appears to be myoclonic jerks. That's going to affect her quality of life, and that really should be looked at as maybe treating it. That's my feeling.
Would you change to Depakote?
I wouldn't. And the problem with Depakote, you already try that, is there's millions of different drugs. So Depakote, I mean, and I know that David Frey wrote down there's like probably 20 different seizure medications. I would actually stick with this current medication, but it's a matter of increasing. When the dose, if it's going to increase, what are you expecting out of it, good and bad? So it's a matter of your eyes wide open in terms of reduction of seizures, but are you then seeing additional side effects? And you're the ones who are going to be the eyes and ears to tell the doctor what you're seeing, but for you to know, and the doctor should prepare you of what to expect one way or the other, what you're going to get out of it, plus what's the potential side effects. That's where the doctors from to you, they should really be telling you the good, the bad, the ugly about all these kinds of things. So you are going into it with a clear appreciation. And then the feedback from me to the family, to me, is, well, what did you see? And what do you notice? And what are you telling me? And I then live and die by the words and the things that you see and you tell me.
Okay. Thank you for the info.
Good luck.
I know we're limited time, but I just want to add a couple of positive pathways. I certainly agree with everything that Seth said, but I want to give you some hopeful pathways to go. One is in relation to what Seth just talked about and planning for later stages in the progression. Since she goes to a TAHAB, I assume it's a larger organization that may have occupational therapists, you may have a case manager. You need to be talking with the organization how they can support your sister, daughter in stages as they go, what services they have available, how they can help you, your quality of life as the caregivers, as well as her quality of life and staying connected to the world. That's one pathway. And so you need to take that pathway. And so Dr. Keller's recommendations are really good to be thinking about that, but think about it in a positive way. The other thing I recommend you do is gather her life story. That's something positive she can do. You can sit down and do, maybe put photo albums together. Maybe you can write down things she remembers, things that give the essence of who she is, that will help all of you as she progresses have clues to why there are certain behaviors, why she may be anxious in places. So those are a couple of positive things. I'm deeply concerned that there has never been that thorough differential diagnosis made, and it was made based on statistics and studies. So I think in a way you help guide the doctor to do that, because every bit of research, at least in the general population, if you deal with the underlying and secondary co-occurring conditions, you can extend the quality of functioning longer for someone. So go into your healthcare providers with specific symptoms, not with the word dementia, but go in, this is what we're seeing, this is today's problem, we need to address what can be the underlying cause, what kind of assessments do we need, and what kind of follow-up. And you will find that will help her and your quality of life as well. And so, also look at the two positive pathways as you think about planning for and how you can make progressive regression over time easier for everybody.
Can I add real quick that the owner of her day hab, she's known her since she's 5, and she's on this call, and she cares.
Good. Then there's one of your
very-
resources. Yeah.
It's like family. The day hab is
Good.
like family. They've
Wonderful.
already assigned a worker to be with Erin at all time.
Good.
And the nurse there is amazing. It's just like a godsend.
Sorry, I didn't mean to
And
get
you
choked
might,
up,
yeah, one just last thing. Welcome them to come. We're going to have lunch and learns. Make sure they get on the list for Catherine to be
I'll
sending
make
out
sure
the
they get
notices.
on. Yeah,
Yes. So
that you're
that's
all on
my
there.
list.
Yeah. Paula Dodd is her name, and she is anticipating learning more because she said there's going to be future
clients
Absolutely.
that come with this.
Yeah.
So she's amazing. We're very fortunate.
Thank you so much for sharing your sister and daughter with us. It is a great delight month after month in this Project Echo to help Texas families. And so it's a gift that you would share her with us. And as you remarked, it's not just helping your daughter and sister, but all her caregivers for the future generations of patients that they will help as well, multiplied by every participant on the call. So thank you for what you're doing.
Thank you.
Thank you all so
Good
much
luck.
for your
Good luck.
information.
Good
Yeah,
luck,
thank you.
yes.
Thank you.
Yeah.
Catherine, I'll turn it over to you to encourage us to fill out the QR code survey and return in November.
Yes, if you would, use your smart little phones there to scan that QR code and just take a minute to complete the survey. As we said up in the very beginning, this project is funded by the Texas Council for Developmental Disabilities, and we greatly appreciate their support to allow us to bring this information to families in Texas and service providers throughout Texas. So if you would just take a moment. It's a quick survey, won't take you very long, and we would greatly appreciate it. Thank you, ladies, for doing that. Our next session is going to be November 19th. Now, having said that, Kathy Bishop, if we don't have anyone on the schedule already, and I don't have the schedule right in front of me, maybe we will do your environmental one next month. And we invite, our family members here today to, to come back to that, to come to all of them, as a matter of fact, but specifically that, and that could be a sort of a good follow-up to our topic today. I also would invite you all, and I didn't put a slide together, but if you are on our mailing list, which you all are, we are starting a series of lunch and learns in Texas. The first one is tomorrow at noontime, Central Time. It's just an hour. And tomorrow is this is Dr. David Frey week, I think. Tomorrow is Dr. David Frey, but he's always popular. And I have to say, we always learn so much from Dr. Frey and Dr. Sadowski about the oral health issues. So he's going to be talking about a different oral health issue tomorrow. So, please join us for that. And, thank you to the Hub team, and thank you to TCDD for their support, and UT Health. And we look forward to seeing everyone next time and tomorrow too. So thank you all. And for our family members, I'll be following up with you afterwards and sending you some resources that were mentioned on the course of the call today, and also making sure you get a link to the recording so you have that to reference as well.
Thank you so
Thank you.
much.
With that, everyone have a great rest of your day.
I didn't.
It was really good.